Um, Good morning to everyone, the participants as well as those who have joined as participants. This is a webinar that has been organized by the Africa Judges and Jurists Forum, looking at the impact of COVID-19 on access to health for all. Um, and all of us will know that from about February, March, when COVID-19 started having its serious impact on the African continent, there were a number of reactions that African governments took, including the creation of a legal framework that would allow for measures to be taken in order to try and limit the spread of COVID as a pandemic. So a number of countries in Africa, in Southern Africa, took states of emergencies, others states of disasters. But the declaration of state of emergency or state of disaster would then have given the government some leeway to come up with measures that would sort of limit enjoyment of fundamental rights in order to try and deal with what was perceived then as a bigger public interest issue, which is the public health of our people. And there's been a number of reactions to the ways in which people were impacted by COVID-19, and in particular the measures that were taken to try and combat it. A lot of people will say, yes, maybe South Africa and Southern Africa have been saved from the worst excesses of the COVID impact itself as a result of those measures. But others argue that, in fact, what started, in fact, Debros Mchana, in a meeting which we had in the past few days, said that it started off as a pandemic, a COVID pandemic, translated into a human rights violations pandemic, translated into a socio-economic justice pandemic. But now it has translated itself into an authoritarian consolidation pandemic, and that shows you that COVID has taken many dimensions outside of just the purely health issue. But on the health issue, we have seen that the COVID pandemic itself is really getting out of hand. Just yesterday, I think the world reached the 100, is it the 1.5 million number in terms of the people who have succumbed and died as a result of COVID, 1.5 million people. And then in terms of the total cases globally, we are sitting around 65 million cases, of which 45,000 are reported as recovered, and we have 18.4 million cases, which is essentially more than the entire population of countries like Zimbabwe, or combined Zimbabwe, Botswana, maybe Swaziland and Lesotho. Everyone that you see would be a person who is infected by COVID if you are looking at the global numbers. And then here in the African region, South Africa still tops in terms of the numbers, where you have more than 796,000 people as having been infected by COVID. And you're looking at about 21.7 thousand people who have succumbed and died as a result of COVID. The total number in Africa is 2.2 million people infected in Africa, and more than 52,000 deaths. And in Southern Africa, South Africa will be 796,400. And the next most affected country in Southern Africa will be Zambia, with 17,730. Then Mozambique, 15.8 thousand. Malawi, 15.3 thousand. Namibia 14.4 thousand, DRC 12.9 thousand, Botswana 10.7 thousand infected people, Zimbabwe 10.1 thousand. Then we have the lower figures in Southern Africa. If you look at the SADC map, and Tanzania is taken as part of the SADC, it has one of the lowest, 509, but it's because there was a deliberate policy government not to do testing and not to be publishing numbers. So Tanzania went against the advice of the World Health Organization around the protocols needed to monitor, track, treat, and try to combat the COVID one. But in Southern Africa, the country that may have the least numbers of people who were infected will be Lesotho, which is at 2.1 thousand. So the numbers in the past few months or past few weeks have generally been increasing to a point where the South Africa President Cyril Ramaphosa declared, is it the Grand Bay municipality as a COVID hotbed because of the fact that we have had a Nelson Mandela Bay because as a COVID hotspot, which may mean that there will be specific action that is taken to localize or to deal with the problem there. In Zimbabwe, we've seen an increase of more than 100 a day or around 100 a day, which would suggest that maybe what the rest of the world is seeing as the second phase of the COVID infection rates, it may also be beginning to come to Africa. And then that raises the fundamental questions around the issue of access to health, the question of treatment, the question of vaccination, because as it is, we still, as I understand it, don't have effective vaccine treatment. I mean, effective treatment for the disease itself. It's only managing it. And then there's also been a development of a number of COVID vaccines, but there's a huge dispute about the efficacy, about the logistical capacity to distribute vaccinations should they be available, but also the issue of storage, given the very low degree of temperature that is needed to maintain the vaccine viable. And the fact that in many parts of Africa, we simply don't have the right amount of energy capacity to be able to have that type of storage. So we're lucky that we have professionals and experts here who have an interest in public health, who will be able to answer some of those. On the news that was happening, I've talked about the new milestones in terms of breaching the 1.5 million mark, which simply means that you are now getting about 10,000 people dying a day in the world. That's a big number. Then the American head of the Center for Disease Control, Anthony Fauci, is reported as having been criticizing the US regulators for approving the Pfizer vaccine without rigorous scrutiny. Then the question of accessibility of that vaccine. President of Zimbabwe, Mnangagwa, addressed the 31st special session of the United Nations and lamented that at the rate we are going, maybe the COVID vaccine is not going to be made accessible to all. And he made a plea to global leaders that we need to see the world reacting to the COVID vaccination in a way that is equitable. So I think all these things, we may be able to cover them during this timely conversation. So we have Memory Kadau, who is the executive director at the Adult Rape Clinic, who is going to give us a few remarks. We have Tumelia Mpepo, who is working as the executive assistant to the Minister of Education in Malawi, which we're very proud of because we've worked with Tumelia for some time. And she will also speak about access to health in the context of COVID for people with albinism. Then we do have Tinashe Mundawarara, who is a public health specialist, and he intersects law and public health, and he will give us his perspectives. And then Dr. Matara, who is a medical practitioner. And thank you to the panelists for coming. This is going to be a live session for those who will be able to join, but it's also going to be a depository on the various social media handles of the Africa Judges and Jurists Forum, as well as the Southern Africa Human Rights Defenders Network, who are collaborating in holding this activity together. And so, memory to kick us off, to kick us off, I would wish that you can just give us your initial general remarks around COVID, the issue of gender and sexual violence, as well as the question of access to health for women in particular, but also people who experience adult rape. Memory, over to you.
Okay. Thank you very much, Arnold. And thank you to the African Judges and Jurists for facilitating this platform. I also want to thank everyone who managed to set aside this time to engage on this important conversation. So yes, COVID-19 has really stretched all of us, as you have said, Arnold. I will contextualize my presentation within the work that we do as ARC on the front line in addressing sexual and gender-based violence, in trying to disrupt rape culture and encouraging a culture of consent through various campaigns, provision of medical legal services to survivors of sexual violence. So the COVID-19 pandemic is gendered. What it has done is it has just magnified structural inequalities that we have been talking about over the years, increasing the vulnerability of women and girls. So in trying to respond to the question, the conversation that we are trying to respond to this morning, I tried to look at the international human rights instruments that Zimbabwe is also party to, and that have ratified in an effort to achieving progressive or progressive realization to the right to health. So basically, our mechanisms are in place, and Zimbabwe has ratified the International Covenant of Human Rights in 1991. It has also ratified CEDAW, the CRC, the African Charter on Human Rights, and also translated the right to health, access to health, in the Zimbabwean Constitution. And we have various legal frameworks and laws, specifically the Public Health Act, that really articulates issues, the right to health, access to health. So in as far as the COVID-19 pandemic, when it was declared a global pandemic, the government of Zimbabwe responded through various measures, which you have already talked about, Arnold, in just trying to control the widespread of the COVID-19 pandemic. And there were also statutory instruments that followed, that included imposition of curfews, restrictive movement measures, banning of public gatherings, and so on and so forth. There was also a personal protective equipment policy that was put in place. The government of Zimbabwe also created a COVID-19 task force, which mainly focused on nothing else but trying to contain the spread of the COVID-19 virus. So you realize in terms of SOPs, policy and legislation, it is considerably clear that in as far as the realization to the right to health it is covered, but the implementation is generally lacking. For example, a few months ago, the High Court ordered the government of Zimbabwe to provide personal protective equipment to health services provider. But however, that access to PPE remains a challenge in public health institutions. So going back to the work that we do at ARC, gender-based violence and rape is a very big problem in Zimbabwe. Unfortunately, it is often undermined and less focus is put into that in terms of investing and responding to gender-based violence, especially prevention aspects. So what COVID-19 did was magnifying this problem. The UN report indicates that one of the places that a woman is likely to die or to be murdered is in her home. So whilst we were locked down in homes and considered safe so that we will not contract the COVID-19, the key question we asked was, were women really safe in their homes and when they were potentially locked down with their perpetrators? And the key questions that we asked as civil society organization, ERC included, is how are government policies or national COVID-19 responses trying to ensure women and girls are protected and safety and protection measures or nets are accessible, especially the right to health. The right to health is really important when we're talking about gender-based violence, specifically rape or sexual violence. If a person has been raped, it is very important for them to access health services within 72 hours to prevent HIV infection, to prevent unwanted pregnancies, to treat STIs, above all, to also treat injuries which could be life-saving for women and girls. So the strict movement measures, what they did is women and girls were sent, what we experience is women and girls were sent back home from the roadblocks whilst trying to access health service facilities. Some also had limited facilities in terms of where they can access services. And very concerning the pronouncement that GBV services, specifically medical services, are essential, was very delayed. So it actually meant most women within the month of April that needed health services could not access them or faced so many challenges in trying to access them, resulting perhaps in unwanted pregnancies, HIV seroconversions, and STIs. Access to courts was also a challenge as courts in Zimbabwe were partially opened. So it took longer for protection orders to be accessed. The court dates were moved, making it very expensive in terms of time and financial resources for women and girls to access justice, especially in gender-based violence cases. Income sources for women and girls dried up because of the measures that were put in place. As you all know, women and girls in Zimbabwe participate actively in the informal sector through selling vegetables, some are cross-border, some are domestic helpers. So it meant that women and girls could not go out and have income. So this also increased their vulnerability to GBV, and even access to health services when they needed them was also compromised. The only solution that was there, because public health institutions were operating at low capacity and there are high costs associated with accessing private health institutions. And most importantly, what we believe is there's a certain, I think you talked about how we all agreed that COVID-19 is a global pandemic, but there was a mutation of so many pandemics that we are trying to we are struggling with at the moment. The UN Women actually declared GBV a pandemic within a pandemic. So there is a tendency to really trivialize or not focus on GBV issues, specifically SRH services, including family planning. There wasn't any integration of GBV services into the national responses. Neither did we even get the messages, especially from the COVID-19 task force, from the president, and from various stakeholders in terms of a strong message sent to perpetrators of gender-based violence that the government, there will be zero tolerance to gender-based violence, and prosecution of perpetrators prioritized as a deterrent measure. So what was also concerning was unavailability of up-to-date data, which would really inform COVID responses to GBV. So what we tried to do also as ARC was to come together with other 5 organizations to address the issue of data, and to also really back our experiences and statistics that indeed gender-based violence was increasing, or it has increased during the lockdown. This report was supported by Safe Zimbabwe and Women's Coalition of Zimbabwe. It generally indicated that there was a 40% increase in gender-based violence between the period of April to May 2020 as compared to the same period in 2019, or January to March in 2020. We even dug deeper, and our statistics revealed that physical violence increased by 43%, emotional violence increased by 80%, economic violence also increased by 42%. These figures really undermine some of the reports that we got through WhatsApp messages, calls, and all that. Musasa Project even reported that the reports that they got multiplied by 20 between March and April 2020. So even as we speak now, we are attending to survivors of sexual violence, predominantly women and girls that experience sexual violence within those periods, especially in April and May. And some are presenting with untreated sexually transmitted diseases, unwanted pregnancy. So they are already past due the stage where they can even ask for a termination of pregnancy within the Termination of Pregnancy Act of Zimbabwe. Some also are presenting with physical and emotional complications as a result of this trauma. So before I conclude, I just want to share briefly in terms of what we did as ARC to respond to this scenario. So although we struggled, I think everyone was really in a position where fearful, and there was a lot of anxiety. And the first thing that people wanted to do was to protect themselves. But what we did was to ensure that our clinics were opened, because I talked about the importance of rape, of someone that has been raped, to access services within 72 hours. So we put in place strict infection control measures at all our clinics to ensure that health service providers are protected, and also survivors trying to seek services are also protected from contracting the virus. So we also adapted to virtual and physical platforms of service provision. This also ensured timely access to services within 72 hours, but it also ensured that women and girls who could not come to our clinics were able to access services, either through referral and direct linkages to services near them, and also providing counseling services over the phone. We also publicized hotline and toll-free numbers so that anyone would be able to call in and get the help that they needed. If they needed emergency health services, would then get in touch with other organizations that offer those services, so that they could provide a shuttle services so women and girls would be assisted. One of the things that we realized, because I talked about pronouncement and declaration of that GBV services are essential, was delayed. So people didn't know, awareness was really limited. So we used radio, television, social media, SMS, WhatsApp platforms, and mobile outreach services to just raise awareness that anyone can access services. And if they just obtain a letter from the police, their chief and anyone that was eligible to give them travel letters, they could actually be able to access health services when they needed them. And the referral pathway, which we worked through with a number of civil society organizations that provided shelter, that have provided emergency post-abortion care, also really helped. So we could directly link with organizations like Roots Africa, who were operating shuttle services for women to pick them and provide safe shelter, Population Services Zimbabwe for family planning services, and safe post-abortion care. The community really played a key role. I think the real heroes of this COVID-19 pandemic are the communities in terms of supporting and spotlighting issues of gender-based violence. So they really played a role in supporting survivors and also raising awareness of GBV cases that were happening in community. Research, we did quite a bit of research to back up our statistics and experiences during the lockdown, because there was a lot of pushback from government, especially that the statistics that civil society organizations were sharing were sort of sensationalized or were not tallying with what they were also experiencing on the ground as government. So what we did is to just back up our experiences and our statistics with research reports that I talked about. These reports also helped with sharing lessons and best practices that could be used in emergency situations, especially in accessing health services by women and girls. We also provided frontline support to frontline health service providers. There was a lot of burnout for health services providers that were just trying to attend to GBV cases and sexual violence cases. And lastly, we built partnerships with government and civil society to raise awareness. So I would really end here. I realized that I have passed my 15-minute mark. I wanted to talk about the challenges and key recommendations and maybe propositions that we could use as a way forward to the challenges that we are still struggling with in Zimbabwe. As you said, Arnold, we haven't passed the red mark. It's more likely we are going to be in the situation where the other countries like UK are. So I think I hope we'll get the opportunity to also talk about what can we do to improve access to health and also to address some of the challenges that we are currently facing. Thank you.
Thanks a lot, Memory. And indeed, you're right that you're going to get a second bite on the apple or on the cherry, because I think these are just your introductory remarks, very detailed, very informative. And I didn't realize you're doing so much work. It's quite impressive indeed, and congratulations for that. And let's get to Meliwa Pepo, and Tumeliwa is from Malawi. As I said, she has moved from working with civil society to now supporting the new government that emerged after the elections in is it May 2020? And the moment I met her, I think it was in 2018 or 2019, but anyway, I think it's 2019. I've never stopped admiring Tumeliwa and her role in advocating for the rights of people with albinism. And when it comes to structural weaknesses that societies have, which create a basis on which groups get marginalized and excluded from the enjoyment of human rights, I think people with albinism will be in the category of people that generally have faced systemic, serial, and sustained marginalization and exclusion, and therefore their vulnerability to a number of factors creates real conditions for a potential disaster when you then get to a situation like COVID. Because COVID, as they say, it deals more with people who have got underlying conditions. But with our societies with underlying conditions of inequality and marginalization and exclusion, COVID has really exposed those inequalities in a way that you can't understand unless you hear from people like Tumeliwa. So Tumeliwa, over to you to just give us a rundown on COVID and access to rights for the people with albinism. Over to you, Tumeliwa.
Thank you so much, Arnold. So as Memo has already rolled the ball, I think I should say COVID has not given us really other problems, but rather it has magnified the problems that were there on the ground. So with persons with albinism in Malawi, the access to healthy has been a challenge during the time COVID started. As a person with albinism, the skin is sensitive to sunlight, and therefore people need sunscreen lotion, also sun protective gear, so that they are protected from the sun. Failure which the sun renders one to develop skin cancer. So during the time when COVID started, and then in Malawi, we had like a partial lockdown. Things were hard for persons with albinism to access the sunscreen lotion. Already there were problems in hospitals and in healthcare centers as regards to availability and accessibility of sunscreen lotion. But then the problems were worsened during that time because I think some of the procurement from the central medical stores to such district hospitals was a problem. And therefore persons with albinism had to stay without the much needed sunscreen lotion. Already in our societies, there are also beliefs and myths surrounding albinism, and during this time, so as an association, so I'm still a member of the Association of Persons with Albinism in Malawi. So as an association, we try to educate the masses about the facts of albinism. So during the time of the partial lockdown, we were restricted on our group gatherings and therefore it was hard for us to still conduct our work to make sure that the public understands more about albinism, and therefore we've also seen some other challenges in that persons with albinism have been encountering challenges as regards to the myths and also maybe the beliefs that other society members have, because they don't know the truth about albinism. Another problem was that considering that the lotion was also difficult to find during this time, other dermatological services were also hard to access during that time. Already the dermatological services in Malawi are centralized, and during the partial lockdown, a lot of things were not accessible. We were rather advised to stay at home. But as a person with albinism, your skin is sensitive to sunlight, and even if you are staying at home or if you are outside your home doing something, an outdoor work, you still need the sunscreen lotion. But also, you also need to be tested if you are maybe having issues with your skin. Therefore, there is need for dermatological services. And since movements were restricted, it was hard for someone to go to hospitals that provide the such skin testing dermatological services. The same challenge was also encountered in access to ophthalmological services, because I think the skin goes hand in hand with the eyes, because our eyes are also sensitive to sunlight. So such services were also not really accessible during that time. So apart from the government, so the government introduces sunscreen lotion as a list of drugs in the health package in Malawi. So part of this sunscreen lotion is procured by the government of Malawi, but it's sporadic. It's not all that it covers the whole Malawi. And therefore, we still have also to depend on donors for the sunscreen lotion. So the Association of Persons with Albinism in Malawi partnered with Beyond Sun Care to establish a local manufacturing plant of sunscreen. So during the time the partial lockdown started, it was hard for ABAM to still be working with Beyond Sun Care, because some of the services that us two as partners were doing were restricted. Therefore, one of the activities that Beyond Sun Care was doing was to educate the masses, the persons with albinism, on their skin condition, but also on how to use the sunscreen lotion. So these activities were put on hold during that time. And you know, it's hard in Malawi for others to it's hard for persons with albinism to access the sunscreen lotion, but it's also hard for them, if they have the sunscreen lotion, for them to understand how they need to use the sunscreen lotion. Therefore, people use it not in the right way. But Beyond Sun Care came in to make sure that people are using this sunscreen lotion in the right way. And these activities were put on hold during that time. So to some extent, we would say that those that had the sunscreen lotion, maybe they were using it in a wrong way, and those that never had it, they didn't even had a chance to use the lotion. Also, with the issues of sunscreen availability, the ophthalmological services and dermatological services issues, we as an association would always embark on advocacy and lobbying with government, but also other institutions. But since this was at a time when the lockdown was there, it was hard to hold such meetings and advocacy campaigns. The only option that was there was maybe to do it technologically, as we are doing right now, holding a meeting online. But then Malawi is one of the poor countries here in Southern Africa, but also the digital divide is high in Malawi, and therefore some of these meetings were hard to come by. Even the local person with albinism will not take part to do such things, and therefore we still struggled during that time to make sure that our healthy rights are enjoyed. In addition to that, persons with albinism also encounter problems in access to sexual reproductive healthy rights services. So we know during the COVID-19, this also was magnified in that, because our awareness campaigns were put on hold. So we know that persons with albinism that were accessing such services also encountered problems during that time. For now, share. Thank you so much.
Thank you, Tumeliwa. Thank you very, very much for that informative brief about the impact of COVID on people with albinism, and the fact that the condition was already existing of inequality and structural discrimination, and that until those are addressed, you find that situations like COVID then create a situation where an already bad situation is then aggravated and made worse. So that is very, very clear indeed from your presentation. So I'm going to ask, I think, Dr. Norman Matara to come in, and Tinashe, because you are more also into the policy, I really think it would be good if at the end of presentations around the factual issues, we would then get someone who has got a policy sort of background and analysis to sort of wind it up. So without wasting too much time, I'll request Dr. Norman Matara to come in. Dr. Norman Matara is the treasurer of the Zimbabwe Association of Doctors for Human Rights. It is an outfit that is composed of doctors who have a desire to use their expertise as doctors to intervene in public causes, especially being able to contribute to, mitigating and maybe treating situations where there's been use of organized violence and torture against innocent civilians and or people who are being targeted because of being human rights activists. So we, as Africa Judges Forum, but also I know with the Southern Africa Human Rights Defenders Network, there is a strong reliance on this group of doctors in terms of dealing with the medical emergencies and psychosocial support that is needed to keep real patriots who get targeted engaged and being physically repaired, but also being mentally and psychosocially repaired. So with those remarks, Dr. Matara, I would wish to give you the floor. I know that your organization has been involved, with the failure of a government response to look after the medical profession and to give them personal protective equipment, but generally also to make the tools of trade for the medical profession readily available in a way that makes them, as the most important fighters of the COVID pandemic, fit for purpose. I think many governments, including ours in Zimbabwe, responded by importing arms and distributing arms and ammunition and riot gear to the security sector rather than buying protective equipment, as well as making our public health facilities better able to deal with the potential numbers that would arise as a result of the infections from COVID. So over to you, and just to give us a sense of where we are as a region and as a country, Zimbabwe. Doctor.
All right, thank you very much, Arnold. Yeah, so for us as Zimbabwe Association of Doctors for Human Rights, we have been working together with other civil society organizations in trying to help with the mitigation of this COVID-19 response. First of all, what we were doing is to do what we call monitoring reports. We have been we've produced 19 monitoring reports since March. These monitoring reports, they serve to track down and play a watchdog role on how the government has responded to the COVID-19 and to come with suggestions where we feel there are gaps and shortcomings. And as you rightfully said, we also managed to support health centers in Mutare, in Bulawayo, in Harare, and also in Masvingo with personal protective equipment, because this was a very big issue, as we saw as an association that personal protective equipment was being mainly based in isolation centers, mainly in Harare, but other people in other parts of Zimbabwe could not access personal protective equipment. So we were able to assist again with personal protective equipment. We are also, as an association, targeting detention centers, because we think that detention centers are at the moment are places of high risk. They are a time bomb because there are people staying in confined spaces, and if there are infection, the risk of an outbreak is much higher. So we are targeting prisons, old people's homes, and children's home, where we visit and see their infection prevention control measures, if they are there at all. You'll be surprised that of all the children's and old people's homes that we visited, they actually do not have any infection prevention control mechanisms in place. They do not have the adequate knowledge on how exactly to do that. So we are going there and assisting them, coming up with protocols on how they prevent infections in those institutions. And coming to Zimbabwe and to Africa at large, in access to healthcare during the COVID-19 and ways to mitigate the impact. I think the first thing that we faced as Africa and Zimbabwe in particular is the issue of health financing. We already had limited public health financing and a stagnant fiscal space in terms of financing our healthcare. Ever since we signed the Abuja Declaration in 2001, we have not been able to meet the 15% which is in the Abuja Declaration of the national budget towards healthcare. And so we already had a problem in terms of our health financing. And when COVID came, it caused further constraints in terms of that the country itself was hit with economic hardships due to COVID-19, and also hospitals which depended on out-of-pocket payments by patients also had little revenue, because most of the hospitals were functioning almost like at 25 to 30%, because most of the services were closed, like outpatients departments were closed. So there was no revenue for the hospitals, yet there was high demand on the health sector due to COVID-19. So this posed a very big challenge in terms of financing the COVID-19 response, because there was not adequate finances, and there was not commitment, especially from our government, to provide funds for COVID-19. If you saw, most of the things were actually, and materials were actually things that were donated by other countries and by other agencies outside the country, like the WHO, UNICEF, and things like that. They were donating to the country, but we did not invest much into financing our healthcare. And so, in terms of access to healthcare, health financing is one of the strongest pillars. And COVID-19 came and exposed the continent. And COVID-19 demonstrated the urgent need to reform the health financing arrangements in sub-Saharan Africa, because at the moment, people depend on out-of-pocket payments, which are not sustainable. We need universal health coverage. We need national health insurance, such that when crises like this come, people have got access to healthcare, and they can finance their health. And the second thing in terms of access to healthcare was service delivery. Service delivery was really affected by COVID-19. We saw that, like in Zimbabwe, as I mentioned before, outpatients department closed, elective theater lists were cancelled, and hospitals were only treating COVID-19 and only attending to emergencies. We had cases being reported to us of people who were being turned away from hospitals because they do not have a COVID-19 result. You had someone who has just been involved with in a road traffic accident. They need agent medical services, but those people were being turned away again because they just did not have a COVID-19 result. So there was disruption in terms of accessing healthcare for other medical and surgical conditions other than COVID-19. There was no protocols to make sure that people continue to receive healthcare for other medical conditions, because whenever we have a pandemic, of course, we really needed to try and contain the spread of COVID-19. But we should have made sure that there are contingency measures to make sure that people continue to access services for other medical conditions as well. And also people with chronic illnesses. You know, with COVID-19, we're always saying that people with comorbidities like hypertension, diabetes, obesity, heart disease, they are prone to severe COVID. And those people, they need to have those conditions being managed and controlled, so that they do not suffer the adverse effects of COVID-19 if they get the disease. But we then closed outpatients departments and made sure that it was very difficult for people now to go for checkups, to go for resupply of their medications, which made possible for people to actually. So it was something that also affected service delivery. We also saw that maternal and child health. There were disruptions in provision of maternal services in Zimbabwe, mainly because health workers did not have adequate PPE. People were not saying that we cannot work without PPE. And also health workers were already on strike. There was labor issues between the health workers and the government. So there were shortages of health workers in maternal departments. And in maternity, people need close and constant monitoring when they are in labor. And this could not happen. As you might know, there were pictures and reports about children dying and stillbirths happening at central hospitals. About 7 reported in one night, one day. So those are the some of the challenges that were saved in service delivery. There was a near to total collapse of accessing healthcare for other medical services, as we mainly concentrated on COVID-19. It also exposed us as a country on how our healthcare delivery system was before COVID-19. So as I think the first and second speaker already alluded to, that COVID-19 just exposed some of the shortcomings that we already had. When we had our first COVID-19 case, we actually did not have even access to intensive care units in the isolation centers that have been identified by the government. And even as we speak right now, I was in Bulawayo last week, and I was actually surprised that up to now there are no intensive care unit facilities to cater for people with severe COVID-19 in government hospitals. So if you get severe COVID, which needs ICU facilities, you actually need to go to a private institution, which is charging almost like $3,000 US dollars as a deposit. So it's something which the majority of people cannot afford. So it means that we already had problems within the healthcare services, and it becomes a problem now when we are hit with a pandemic. It becomes difficult for the government to put in place a very good health system in, let's say, to get COVID, when it becomes very difficult to do that in a short space of time. So it's also a, a lesson to governments that healthcare, we
Are we facing instability with the doctor's Wi-Fi, or it's me, Mamu?
He seems to be having technical issues. Yeah.
Right. I think he had already said so much in terms of the professional assessment of the way in which our authorities reacted to the COVID pandemic. The question of absence of public health facilities and a preparedness to admit a significant number of people into the ICU, intensive care units, especially what you said about Bulawayo, is still a tragedy that up to today, the public health facilities of public hospitals do not have capacity to even admit one person into an ICU, and that process is being dealt with through private hospitals where the minimum charge before anyone can be admitted is 3,000 US dollars. It simply means that most of the severe cases of poor people is a sure case of a death sentence, and we should not run our public health facilities that way. as African countries. So now what I will do is to ask Mr. Tinashe Mundawarara to come in and give us his perspectives as well. You know, Tinashe is one hell of a lawyer from Zimbabwe. He was, he started off with media work before he joined the human rights institutions and sector, like Zimbabwe Lawyers for Human Rights, where he then actually got interest to study law until he got his own law degree and got registered to practice. But beyond that, he is one of the very few lawyers who have intersected, you know, human rights law practice with public health policy practice. I know when we were working together at Zimbabwe Lawyers for Human Rights, Tinashe, that you are the one who was instrumental in the development of an HIV/AIDS charter for Zimbabwe, and getting everything that needs to be done from a policy perspective in a single document that would then be able to influence national policy around the effective treatment and mitigation of the impact of HIV and AIDS on communities. And so I'm very, very interested. I know you also helped the Southern Africa Human Rights Defenders Network to draft a policy framework that encouraged a regionally integrated approach to dealing with COVID quite early during the time COVID was still you know, coming into Southern Africa in February, March. So from that perspective, I thought it would be good for you to come at the end, because listening to the wonderful presentations that have come from our panelists, it may also give you a process where ultimately we can move towards policy analysis of the response that the governments have done on HIV/AIDS. I mean, not on COVID-19 and access to health. So over to you, Tinashe.
Thank you, Arnold Tsunga, and I also like to thank colleagues who are on this webinar and my co-facilitators on this webinar. Thank you very much for taking time to attend to this webinar. Generally, what I'm going to do is to really give a brief on terms of what policy is, and then the considerations of policy gaps. What do we mean by policy gaps? And then I'll go into some of the key issues of considerations and indicators around what policy should provide in the context of COVID. And then I'll probably look at what policy gaps have presented as opportunities in the response to COVID. So basically, when we look at policy, we are looking at the things like the laws, the regulations, government plans, government programs, jurisprudence, and there's also the aspect of policy as practice. And then we, I mean, from those who have attended medical school, when we talk of policy, we're also talking of treatment regimens and clinical protocols. So in terms of the response to COVID-19 and looking at policy gaps, we're looking at also whether there is absence of policy, whether there is inadequacy of policy, whether the policy promotes exclusion, whether the policy does facilitate the violation of human rights, gender inequality, and also whether the policy itself is a product of the use of science. Because as you understand, COVID-19 is a medical issue, it's a medical problem, and therefore policy should be based on science. So when policy comes in with the inadequacies of science, then there is a gap in that particular policy, and also the aspects of discrimination and inequality. But the whole sum total of policy analysis or considerations with respect to policy responses to COVID-19 are anchored by the concept of the right to health, and particularly the three key issues of availability, accessibility, and affordability. I think my colleagues have also touched on these issues, especially Dr. Matara, who has spoken a lot about these three aspects of availability, accessibility, and affordability. If you also look at the aspect of COVID-19 and lockdowns, you'll probably see that in terms of responses and access to health services, there is a lot of access that is facilitated by what I call biocitizenship. Biocitizenship, I'm particularly talking about, for example, people living with HIV who function and work in groups, support groups, and also as associations, who, for example, when they are locked down, they cannot probably access each other and support each other, and probably do work around promoting adherence of their members to medication, things like that. And you also have to look at some of the marginalized groups, like the LGBTIQ plus groups, and in terms of them belonging to a certain category of citizenship that is anchored on, or that has got a closer proximity to health access issues. So the other thing that is very important in terms of the lockdown considerations is how they have eroded the household economies. And like you heard Dr. Matara say that much of, I think, more than 80% of healthcare financing in Africa, and Zimbabwe in particular, is out of pocket. So when people fund their healthcare from out of pocket, and then lockdowns erase household economies, that basically means that households cannot afford to pay for healthcare services, and this impairs their access. So also the other thing to consider is the aspect of choice, which is very important in terms of the right to health, because you've got to have a choice of the medical practitioner that you have to attend to you. You've got to have a choice of the medication that is available to you. You have to have a choice of the health facility to visit, etc., and things like that. But when you're under lockdown, you have to do with what is available. So in terms of the freedoms that are associated with the right to health, policy has been unable to facilitate those kind of choices. Then the absence of health insurance policy around COVID and also affected access to health services. And if you consider the industrial layoffs and the job losses, they also bring along in their train the erosion of health insurance, as it were. So that is also another aspect. Then the aspect of chronic diseases, where people were unable to access renal failure services and other services that are critical to chronic disease that should be regularly accessed by those groups. So you would then understand that certain groups have to negotiate exclusion, cost, discrimination, distance, language, etc., to be able to access health services in the era of COVID-19. So I would like to highlight a number of key policies that probably has gaps in terms of the implementation and how I've seen it. For example, the aspect of the resource mobilization policy in this country, and also I think in countries in Africa, there's been poor implementation. And I think also goodwill have been erased through resource accountabilities being weak and corruption creeping in, etc. So there's has been a loose mobilization strategy, but also a management of the mobilized resources that are there have also been inadequate. But when you look at the health system response, when you look at the health system and policy, you want to look at policy gaps. Then there's the aspect of the policies themselves being absent around, say, the curative and clinical practices, for example. You don't know, it was not clear even, I'm not sure even now, in terms of what are the treatment regimens that are available to Zimbabwe and what is their efficacy in terms of how government have formulated that policies. I highlighted in the beginning that COVID-19 is a medical issue, and therefore some clinical protocols, which are the most important policies in terms of those that are in the medical practice, you have to be, I think, standardized in terms of international practice. And there's not been a clear practice from central government in terms of how Zimbabwe was drawing up its clinical treatment protocols, the regimens, etc. And even if you see the first cases, if you do go back and look at the first cases around mortality in terms of COVID-19, the first person who died, and when he was taken to the clinic, there was no clear case management guidelines. He was left there, and people were reacting to whatever was happening at that particular moment without following any guidelines, which shows that the aspect of the health system in terms of the management of patients was absent. And also, I think also there's also gaps in policy of training health personnel in terms of being experts around responding to the pandemic. I think I have to be fast. I sense that communications, a lot of disinformation and propaganda. And I think also there's misinformation around what would be transpiring in the country and what people ought to do. Then there's also another very big policy gap, which is the use of big data. Big data, it helps to, by saying big data, I'm trying to refer to the use of IT resources to manage national responses to COVID-19 using a lot of data, which is computerized and able to inform policy and decision making. So that is absent, and that has been absent, the use of big data in terms of the healthcare system in Zimbabwe. And this has become so apparent in Zimbabwe during the COVID-19 era, because it has actually shown that the government is just working without any basis at all, and the decisions that they are making are half-baked and not supported by science, but probably a copy and paste from elsewhere, because their own capabilities in terms of policy are very weak. Then there's aspect of social protection policy. I think I don't need to go on that because my colleagues have also touched on that. Another aspect of policy gap is around the access to water, sanitation, and hygiene services, because there are communities generally that do not have water and probably take water from a distance, even in the urban areas and the informal urban settlements. So what we then have is that these people were in lockdown and they could not go out to access water, potable water. So this was an exacerbation of disease burden in these communities. And also the same with provision of education, it was disrupted. So one other key issue that I would probably want to highlight is a policy gap in terms of the response to COVID-19. There has been the lack of policies to manage the transitioning of lockdowns in a way that when the country is lockdowns, there should be an issue of equality and solidarity in the processes, because it should not be divisive in terms of social class, race and gender and things like that. So that is also another aspect of consideration. But let me go into the policy gaps as opportunities. You see, there is the aspect of e-government, which should be promoted because you need to be paperless and there is less interaction. That is another policy consideration. Then the aspect that the chance to mobilize resources for health has been presented by COVID because it was affecting everyone, and politicians were given the nudge or the push to consider COVID as a threat and resources as a way out of this. And also the aspect of improving IT infrastructure. Education is impaired in the rural areas because there's no electricity, because there's no IT infrastructure. That is also another opportunity where, for example, resources could go there. And then the aspect of updating our education curricula in terms of the health services and training of health personnel in Zimbabwe. And even the security personnel, for example, there's the aspect of biosecurity, which can be a subject of interest in terms of training the security forces like the army and things like that. Then the last one, I think, probably is the strengthening of the health system as a positive that have come out from the COVID pandemic. So I think on that note, Arnold Tsunga, I would probably have to wait for other interventions or questions and end here. Thank you very much.
Thank you, Tinashe. We knew we could count on you in terms of giving an overall policy analysis to see gaps that have been there as a result of the inability of our governments to effectively respond from a policy perspective to the needs for ensuring that the pandemic as a public health issue is dealt with in a way that does not reduce, but in any case enhances access to public health, especially for the vulnerable, for the marginalized, and those who generally suffer exclusion as a result of the serial and structural inequalities in our societies. So I think that was very, very good. I see that Dr. Nomen Matara is back. I wonder, Doctor, whether you wanted to conclude or you wanted to say something in your presentation. We're going to be going into question and answer session, but I think you had started talking a little bit about vaccinations. Maybe you may want just to give us a global overview of the potentiality for treatment, potentiality for vaccination, and its access, especially to Africa. Dr. Matara.
All right, thank you, Arnold. Yeah, so in terms of treatment for COVID-19,
Dr. Matara, sorry, do you have a video or you don't? I'm not insisting that you should go on video, but if you can give us maybe 1 minute and then off, but otherwise you are really free to speak without it.
All right, yeah, my network is a bit poor.
Okay, so go ahead then.
Right.
Go ahead then. Thank you.
All right. Yes, so I was saying that in terms of treatment, there is no current treatment for COVID-19, and it is caused by a virus. There isn't any treatment to cure viruses. So our only hope at the moment is if we could get a vaccine, then that's where our hopes is. And at the moment, just to give a background on how vaccines are developed, they actually go in stages where the preclinical testing, where they are done on animals, such as mice and monkeys. They go on to the phase 1 safety trials, where they are given to a small number of people to test their safety and dosage, and also to confirm that they stimulate an immune response. And then there's the phase 2, which are called the expanded trials, where the vaccines are given to hundreds of people, are split into groups, such as children and elderly, and see how they affect the different types of groups. And then there's the phase 3, which is the efficacy trials. And these are when the vaccine are given to thousands of people, and they want to see how many become infected compared with volunteers who receive a placebo. So most of the vaccines that have been talked about in the past few weeks actually bring out results from the phase 3. And after the results from phase 3, then we go to the approval phase, where regulators in different countries, they review the phase 3 trial results and decides whether to approve the vaccines or not. As you know, the UK 2 days ago, they actually issued out emergency authorization for one of the vaccines, the Pfizer vaccine. So they become the first country to ever approved the Pfizer Pfizer vaccine based on the phase 3 results. We already know that China and Russia have also approved their vaccinations, but there have been a lot of debate that they authorized them without phase 3 trial results, and they rushed to approve those vaccinations. So most countries have actually not yet approved, and we are still waiting for the approval from the FDA for these 5 vaccines that have now started issuing results of their phase 3 clinical trials. And looking at Africa at the moment, we seem to be not prepared enough to receive the vaccines. According to the WHO, they issued out an assessment tool on the 47 countries in Africa to assess their readiness for the vaccines. And the WHO said we really need to do a lot of work in terms of preparedness because at the moment, only 49% of the African countries that we assessed have identified priority populations and have plans in place to reach those priority populations. Because when the vaccine first comes, it will be in limited supply, so it's not going to be given to everyone. There are populations who are at risk populations, like frontline health workers, like those with comorbidities. Then they need to be identified first, so that they get prioritized for the vaccines. And the WHO also noted that 44% of the countries had coordination structures in place to deal with that, and that only 12%, only 24%, sorry, have adequate plans for resources and funding, because the WHO said that at the moment they are only able to provide vaccines for 20% of the African population, and also that the countries they would need to finance for the delivery and the consumables, such as like the syringes, to make sure that the vaccines are delivered to the intended target. So it will cost us about $60 to $2.50 per dose for as cost of vaccine delivery. And we will need you need 2 doses per individual. So that's amount to at least something between $3.20 to $5 US dollars per each individual whom we are going to be vaccinated. So countries need to prepare to finance that, and only 24% at the moment are prepared to do that. And then lastly, in terms of the vaccination, the trouble again with the vaccination is that it is made from what we call a messenger RNA particles, and they need to be freezed to minus 70 degrees Celsius for them to be transported before they are injected. So it also becomes an issue with cold chain transportation. We already have a problem with that, like in Zimbabwe, in terms of making sure that vaccines are protected when they are being transported to delivery. We do not have adequate cold chain mechanisms. But one of the companies, Pfizer, which is one of the leading companies with the vaccine, have said that they are building boxes that will keep the vaccines cold during transportation. So maybe if they provide us with that, it will become better and easier for us. And also another challenge is that the vaccine is given in 2 doses. So we already know that there are vaccines like the hepatitis vaccine, which are given in divided doses. We usually have challenges with people coming back for the second dose. So it will be a challenge again for us to make sure that people come back. And also another thing that we need to do as governments is to make sure that we have communication systems in place to prepare people for the vaccines. There are a lot of myths and misconceptions being peddled on social media right now about the vaccine, that there are conspiracy theories about the Third World Order or something like that, that these vaccines are meant to cause mutations in people or to make us underpopulate so that we will not conceive when we get these vaccines. So all those things have to be put in place to make sure that the vaccines are received, because developing a vaccine is just the first step in a successful rollout of a vaccination. But having the vaccine accepted by the community and able to roll out is the other most important part of a vaccination program. And at the moment, the WHO said only 12% of African countries have plans to communicate with communities and to build trust and demand for the COVID-19 vaccination. So we are still a long way in making sure that our people are well informed about the vaccine, that it's something that is safe, and structures to make sure that people accept it and have it delivered to the people. Thank you.
Thanks a lot, Dr. Matara. That's quite a bit. And the preparation of people for treatment in the context of a trust deficit. The the type of energy that is needed to achieve minus 70 degrees Celsius, which is the storage temperature and transportation temperature. And then the few number of African countries, you say 25% that may be ready to actually be able to deal with the logistics. So you might find that the development of a vaccine in wherever it is being developed, first world countries, China, it's not matched by a desire at the level of African countries, at the level of authorities, to start preparing on how to engage communities and how to ensure that there can be proper distribution channels. And that's quite sad, because you know, when other societies are already involved in huge investments in research and development, our job will have been easier to already start preparing the channels for distribution. But again, we seem to be short. It's like, you know, it's really something that is of concern for our continent. So yeah, the administrator at ICJ, at the Africa Judges and Jurists Forum, had put that we can get into questions and answers. So if anyone feels that they need to have a brief question or a brief response, including those who may be in as panelists, you could just indicate by raising your hand. My view, the hosts, is that because of the numbers that are there, if anyone from the attendees feels that they want to ask a question, we should be able to elevate them to being a panelist so that we can get their views. We're just left with about 10-15 minutes maximum. So it's open to colleagues. Tinashe, you're connecting. You want to respond?
Sorry,
I
didn't get to the question.
No, you've unmuted. I was wondering whether it's a statement of intent to speak.
Actually getting into the, my internet had dropped.
Oh, okay, perfect.
I didn't hear anything.
No, that's fine. Then Memory, you had spoken to say that you had some quick recommendations. Would you mind giving us those recommendations? And I would say this is basically your last opportunity to speak, and I'll give everyone else the last opportunity to say a few remarks for maybe 2-3 minutes, if you can summarize. Thank you.
Thank you, Arnold. But most of the recommendations or propositions were actually mentioned by other speakers. The only thing I think was around, but I think most of them were mentioned around the Abuja Declaration, 15% or commensurate funding in terms of the health fund. The only thing maybe perhaps monitoring, which I picked that can be a key recommendation, but already SADA is doing that it is really important to monitor and ensure that the long-term policy design and programming is not impacted by shifting priorities as we respond to specifically COVID-19. For example, Agenda 2030, issues around improving access to health and issues around HIV/AIDS. So for me, I think that's the only thing that hasn't been said. Oh yes, there's another point. I think the identification and strengthening of community structures. I also talked about that. They really play a key role in COVID response, and in our case, in terms of trying to address issues of gender-based violence and the responses to protecting and supporting women in communities is really important. Everyone spoke fully around advocating for the integration, a holistic approach in terms of how government and other stakeholders are responding to COVID-19 and other components that are viewed as life-saving interventions. So for me, I will end here. Those were my few recommendations that I have. Lastly, I see on my notes there is litigation, which in our case I have seen SADA do a lot in terms of. I think it is important. It is not enough by itself, but coupled with a number of strategies, litigation is also important as it changes attitudes. It also holds duty bearers accountable, sets precedents, and can identify gaps in terms of policies that have just been talked about. So for me, those are the few recommendations that I had on my notes. Thank you.
Thanks a lot. Very practical. Can I ask Tumeliwa, would you have your last minute or two just to give us what your takeaway and final recommendations to the participants and audience and those who listen to this video once we post it on our online platforms?
I think a lot has already been said on the recommendations. I think it's high time that we implemented our policies accordingly, rather than keep on complaining of the challenges that are there in our communities. In addition to that, I think COVID-19 has come at the right time to make sure that it has made us awake to what has already been in our communities, and then we need to be vigilant in making sure that we address all these issues at hand. We shouldn't be able to. We should not in future say similar challenges that we are facing now, but rather this should be a learning point to make sure that when we are faced with another pandemic in future, we are able to deal with the issues that are there. Thank you.
Thank you. And obviously, the question of preparedness to deal with pandemics in future is directly linked to how we organize our societies, which is also directly linked to the question of governance. And I think better governed and countries tend to respond better to crisis because there's also an issue of leadership responsibility and accountability. Thank you, Tumeliwa. Tinashe, would you want to give your final remarks, a minute or two?
Okay, thanks, Arnold Tsunga. I just want to conclude by saying that while there's been much emphasis on individuals in terms of stopping the spread of the COVID-19 and so forth, I think we, in terms of our African government, we need to understand that change needs to go beyond the individual risky behavior, and to paraphrase what one thinker said around the promotion of health being a social science, and then large-scale benefits coming from political rather than individual change. So the centrality of it is that the gist of this is that around promoting a healthy and fair society, we need to acknowledge the centrality of wealth redistribution, public provision of services, and social protection for us to have that. So I just wanted to highlight that it is very important to go beyond individual change to have a beneficial change that promotes health coming from political change rather than individual change. Thank you very much, Arnold Tsunga.
Saying you remind me, Tinashe, when I speak like that, there's a news item I read, is it yesterday or today, that the Prime Minister of Eswatini had to be moved to South Africa in order to try and accelerate the rate of recovery. And if you look at the numbers, that South Africa is in excess of 700,000 infections, and Eswatini is less than, what, 5,000? But then it also shows you that, which means even at the highest levels in that country, despite the low numbers compared to South Africa, there's still a belief that the facilities in the country are not sufficient to deal with COVID once it attacks at that highest level, which really shows how our societies are unable to organize themselves. And at the level of leadership, where there is the greatest burden and responsibility for leadership, there isn't. If anything, they use the proximity to national resources to actually escape to other jurisdictions for better treatment. And so it's happening at a wide scale in Africa, that from what Dr. Matara said, that despite the fact that other jurisdictions outside of Africa have developed a vaccine, which is a huge investment, but Africa hasn't been preparing itself at the level of organization to have a distribution capacity. And which means we'll still find ourselves unable to get effective treatment even if the vaccine is discovered. And what it means is that the citizens of the Western world, China, Russia, are likely to get preferential treatment in terms of distribution of the COVID vaccines. And one of the concerns that is there, obviously, is that the herd immunity, which is generally estimated and at 70% of the population, we have had the fortune of not having serious infections, but the negative impact of that is that we will also not reach our herd immunity quick enough, which means Africa will have to rely on vaccinations if it is going to reach the 70% mark to achieve the herd immunity. So we really have scratched the surface in this conversation, and I think we need to have another conversation that digs deeper into these issues, because these are the issues that are a reality. Especially, maybe the next conversation will have to be what level of organizational competences we need for us as Africa to improve. So, Dr. Matara, your final remarks, then we move towards closure, unless there's someone from the audience who wants to say something.
Thank you very much. My final remarks would to say that COVID-19 has come and has taught us many lessons in terms of the right to health, and that one of the things that we have forgotten, but which is very critical, is the issue of primary health care. We really need to resuscitate the primary healthcare facilities in Africa, such that people can easily access healthcare, and they play a vital role when pandemics, which forces people to restrict movements like this, happen. You see, if we had clinics which are running well and with health professionals who are qualified, operating very well, it will be easy for them to conduct screening and testing, which limits people moving. But the primary healthcare facilities have been not functioning well, and it posed a problem as people had to rely on central hospitals. So yeah, it's just the need for us to resuscitate primary healthcare. Thank you.
Thanks a lot, Dr. Matara. Your contributions have been invaluable today. May I ask maybe Mamu to elevate our Secretary General to the speakers to ensure that we can get concluding remarks. But as you do that, there's a question that came from the Facebook live session, which goes, how are you going to make sure the vaccines get to the right people? Although they have low street value, they still can be stolen, embezzled, and used for political patronage. This arose as a question from the Facebook stream. Memory and Dr. Matara, Tinashe, does anyone want to take it? Is there anything happening?
No, we see. Yeah, everyone seems to be on mute.
Oh, okay. Tinashe, do you mind replying the Facebook message, or Dr. Matara? I think something has happened with our platform. Dr. Matara, yes, please go ahead. Unmute yourself first.
Yeah, can you hear me now?
Yes, perfectly. Thank you.
Yes, doctor, please go ahead.
Okay, yeah, I think it's a very important question coming from from Facebook. I think the issue of accountability has been talked much about, especially in COVID-19. We've seen a lot of things like donated things being looted and things like that. So it becomes particularly very important that we make sure that we hold the government accountable for the COVID-19 vaccine. Unfortunately for us, the COVID-19 vaccines do not come directly under government. Of course, they are delivered through the Minister of Health, but we have WHO agencies like Gavi, which deals with vaccines in Zimbabwe, and they've got a lot of experience in dealing with in providing vaccines. So it will be very difficult for those vaccines to be looted because they won't be dealing directly with the government, but usually with the WHO agencies. They are there in terms of making sure that the vaccines reach the right people, and they've got accountability systems within their systems as well. Because the vaccinations, all the vaccinations, they've got registration numbers, and for every vaccine that is given, is actually documented which person received that vaccination, with the registration number, the expiry date, and things like that, to make sure that if there are negative outcomes like side effects or complications that arise, they can actually trace back to the batch of the vaccines. So I think that there are really accountability systems which are already in place, not only for COVID-19, but for other vaccines that we've already been given in the country. And I'm sure that even with this COVID-19 vaccine, we will actually be able to use those systems as well.
Thank you, Dr. Matara. It's my time now just to thank all the panelists for your very articulate presentations on this important topic. And I'm now handing it over to our Secretary General at the Africa Judges and Jurists Forum, Martin Masiga. We are privileged to have you, sir. Please. Martin, do you mind unmuting yourself if you are speaking so that we can hear you? Okay, in the absence of Martin being able to join us, I just wish to thank the presenters, and I want to thank the back room staff for organizing this event, Washington, Katema, and in particular Mamu, for your hard work in designing the program and being able to identify what I think are brilliant presenters who had a very strong complementary role with each other in terms of dealing with the topic of COVID-19 and access to treatment and health for especially the most marginalized and vulnerable and usually excluded as a result of inequalities in our societies that we inherited after the struggles for independence. And I really recommend that colleagues who are here commend your friends, technical partners to go through the Africa Judges and Jurists website, where this video of this conversation is going to be deposited. I think it's the wealth of knowledge and wealth of information that has been placed at the disposal of communities online as a result of your contribution is absolutely invaluable and worthwhile to continue utilizing. So with those remarks, thank you very much. And I would suggest our hosts to put this discussion to a close. Thank you.